Hello, I'm Matthew Weinstock with Hospitals and Health Networks. From payment cuts to implementation of the Affordable Care Act to significant changes in the marketplace, 2013 is shaping up to be a transformative year in healthcare. And it should be a busy one for Dr. Benjamin Chu, the new chairman of the American Hospital Association. A primary care physician, Dr. Chu began practicing in public health in New York City. During a career that spanned both clinical and administrative work, he's run outpatient clinics, emergency departments, and led hospitals and health systems. He currently serves as regional president of Kaiser Permanente, Southern California and Hawaii. He joins me now to talk about the AHA agenda for 2013 and issues impacting the field. Dr. Chu, thanks for being with me.
Hey, Matthew. Always a pleasure.
So we're experiencing in Washington a lot of debate over the budget that will clearly extend for the year, if not beyond that. As the new chair of the AHA, what's your message to lawmakers as they grapple with some of these complex budget questions?
I think the key message is that things are really changing in the healthcare delivery world, right? Some of the core incentives that we've had for many, many years are actually changing with the Affordable Care Act, and I think changing for the better. We're moving from volume-based payments to value-based payments. We have the hospital engagement network that's out there that's absolutely working hard to transform the care that we deliver to make it safer and much more efficient, right? And I think that the message to the lawmakers is that we have to give time for those changes to take hold. A premature focus on the budget with the idea of just slashing payments actually could undermine that effort.
You're somewhat of a self-described political junkie, so you know that that's really not the way DC operates a lot of times. It is more reactionary. So are you confident that lawmakers and policymakers will give time for some of these transformations to take hold?
You never know in Washington, right? But I'm hoping that people will, because you look at some of the changes that have happened, and of course one data point is never an accurate gauge of what's going to happen long term, right? But if you look at last year, the Medicare per capita increases in spending was only 0.4%, virtually flat, right? And really what the problem with the federal budget is that the demographic explosion is going to accelerate the federal share of healthcare spending. So we're adding 10,000 new Medicare members, net new members a day to the Medicare rolls. And by 2030, there will be 75 million Medicare beneficiaries. So that's what people are struggling with right now. But the time horizon to address that is actually a much longer time horizon. So if we rush in the next year or two to slash the budgets, thinking that we have to do it now in order to get the savings 10, 20 years from now, well, it may be just a little premature, and the thing is that hospitals are vibrant parts of communities that we serve, and we're changing. We're actually changing. I'd like to see the federal government give the hospital world and the healthcare world a chance to show that the 20 or 30% inefficiencies that many people are talking about is actually gettable.
And do you feel like you're seeing that traction take hold in the field, that some of these transformations are taking place?
Oh, absolutely. We're just in the first year of the value-based readmission policy, or the changes to that actually bundles complications into one payment system. And already we're seeing a 40% drop in central line associated bloodstream infections in the ICU, right? And I'm sure that in the next year or two, we're going to see large drops in readmissions because, the hospital world is focusing in on the transitions in care and putting in place, principles as well as protocols that others have shown can actually be better for our patients and reduce the readmission rate. So I actually think that giving it time is not, is not just throwing up a hope and a prayer. It's actually allowing things that we know actually can work to take hold.
And so you're at a large integrated delivery network that has been able to achieve some of that, but you also started your career in the public health system. How hard do you think it's going to be for the independent community hospital to move towards that model of integration that you're talking about?
Well, I think if you bundle the payments and the bundle payment has enough resources to do a lot of the work that you do with transitions in care, especially if it's a bundle payment with the doctors where everyone has the same incentive. On the other hand, there is the movement in this country to consolidate. More and more hospitals are joining larger systems, and I think it's inevitable that we're going to be delivering care in larger and larger systems, simply because you need the scale to make the investments in information technology, in population care management tools, and in teams to be able to handle so much more of that care that doctors can't do on their own.
So you've talked a lot about the relationship of the hospital and the clinician. What role does the clinical leader play in this transformation, and where do you see them fitting in?
Well, I think the clinical leaders have to be part of the solution. The separation of the physician community and the hospital community has always been artificial, right? And if you think about the coordination that's necessary to do the best job we can for our members and our patients, it's got to be a collective effort, right? An individual doctor simply can't provide all of the resources necessary to coordinate all that care. Hospitals can't do it on their own, but hospitals have resources that can complement what a doctor can do.
Do you think that there's enough training going on now to help clinicians move into those leadership roles within hospitals?
I think that the biggest challenge facing healthcare today is leadership development. And whether you're a doctor or you're a hospital administrator, the tools that have to be brought to bear are different. It used to be very easy to be a hospital administrator, when the reimbursement system was solely built on fee-for-service. All you had to do was keep your hospitals full. On the other hand, the idea that you're taking responsibility for a population, whether it's a fully capitated model or whether it's a shared savings model, but it's a larger responsibility for an individual's health over a longer period of time, then you really need to be able to work with other people. You have to be able to get doctors on board. You have to be able to get community resources on board. Communication is a key ingredient. The ability to leverage relationships has got to be a more focused part of a leader's training. And then you have to get the doctors to do the same thing in a way. You can't be part of a team if you're a sole agent.
So to your point earlier, it was somewhat easier, as you said, to be a hospital administrator. Now, right, you've got to reach out to your community at large and really expand the scope of what you're doing.
Absolutely. I actually think that that's true. If you think about the determinants of health, so much of it is about behavior, about the environment, the community environment that's out there, right? It's about educational levels and economic opportunity. I'm not saying that hospitals have to take on, all of society's problems, but we have to be part of the solution, right? We have to understand that we play a role there. We are vital parts of the fabric of the community, and we need to work with, faith-based institutions, schools, all sorts of community resources to try to optimize the opportunities for people.
Great. Dr. Chu, I appreciate you taking time with me today.
Thank you, Matthew.
For more of my interview with Dr. Chu, be sure to check out the April edition of Hospitals and Health Networks. I'm Matthew Weinstock. Thanks for tuning in.